This is the lecture for Chapter 12 on surgical interventions and postoperative management. So we're going to start with the indications for surgical intervention. So at first, if someone has incapacitating pain at rest or with activity, they may benefit from a surgical procedure. Typically, they will have tried some sort of a conservative management, usually physical therapy or other medications prior to surgery. They may have a severe marked limitation in range of motion. They may have gross instability to a joint or a bony segment. Again, this has to be to the point that it's no longer functional for this patient. They may have a joint deformity or abnormal alignment that's severely impairing their ability to perform activities of daily living. They may have severe structural degeneration. An example of this would be someone who undergoes a total knee or total hip joint replacement. A patient with chronic swelling may benefit from surgical intervention, or they may have had failed, again, all of these non-surgical or more conservative type management, so at this point they're progressing to a surgical intervention. So again, all of this has to result in a loss of function that leads to severe disability that will require surgical intervention. So before surgery, if we can provide any preoperative patient education, this will be beneficial for our patient. So usually the things that we'll review is kind of an overview of their plan of care. So basically explain what to expect, what the post-op plan is, maybe review their post-op precautions if they're not supposed to flex their hip above a certain angle, like 90 degrees, make sure they know that before they undergo surgery, because usually people are a little loopy after the procedure. You may want to review how to use crutches, what their weight-bearing precautions are, things like that. You'll want to review bed mobility and transfers if that's something that may be challenging because of their restrictions. Again, maybe they have a hip flexion restriction to 90 degrees. You may also want to review those post-operative exercises, so maybe isometrics, ankle pumps, deep breathing type of exercises, again, teaching them before they have surgery, and any gait training, again, maybe use of crutches or cane or walker, something like that. You'll also want to go over wound care, so discussing signs of infection, things to monitor with their incision, and how to manage that. So considerations for post-operative management. We've talked about this a little bit in class, the different phases of our rehab. Your book kind of breaks it up to maximum protection phase, moderate protection phase, and minimum protection phase. So we can think that our max protection phase is similar to our acute phase, or our, again, just protection phase. So we want to initially have low loads, we want to manage the inflammation, we want to protect the tissue, and again, our rehab is dictated by our slowest healing tissue. Our moderate protection phase, this is kind of that intermediate in-between phase, kind of like our subacute phase or our controlled motion phase. Again, pain and inflammation should be decreased, so at this point we're again working on increasing range of motion and increasing strength. Our minimum protection phase is similar to our chronic phase or our return to function phase, and at this point our patients are a little bit more advanced. At this point they should have no range of motion restrictions. Their strength should be pretty good, should be at least a 4 out of 5, so at this point we're working on functional type of activities. Our progression or our protocol that we may follow, again, potentially prescribed by the surgeon. You typically want to follow more of a criterion-based protocol. Some surgeons have time-based, so they say by week 2 you should have this much motion and this much strength. Usually a criterion-based progression is more functional for our patients, and it allows us to better determine when they're ready to go on to the next phase. Some potential post-operative complications and risks, so things that we want to consider. Pulmonary complications, so this could be increased risk for pneumonia or atelectasis, which is our collapsed lung. This is going to be highest during those early post-operative time frames, so within the first couple hours or maybe the first day. Patients may be at risk for a DVT. This often is increased with someone who undergoes a total hip or a total knee arthroplasty. Depending on the procedure, some people may be at risk for subluxation or dislocation, again, especially if the joint capsule has been cut during the surgical procedure, if someone is maybe a little bit less stable, or they have some impairments to the muscle surrounding the joint. So these people may need a brace or some type of assistive device. People may have restrictions in their motion, again from either adhesions or scar tissue. And ultimately, you can have a failure of a surgical procedure or loosening of an implant that was put in. So this typically will occur early, and this may occur if there's been excessive weight bearing or things haven't been given the time to heal that they need. So kind of an overview of common procedures and different ways to manage this. We have different surgical approaches. So the picture on the top right would be considered an open procedure. So this is where they're going to make a very large incision, and then they're going to open the tissue so that they can visualize everything that they're doing. The picture on the bottom is an arthroscopic procedure. And this is where they make small incisions and they insert these different cameras and tools so that they can do their procedure arthroscopically. You can also have what's considered a combination of these, an arthroscopically assisted procedure, where they have to do maybe a small incision to open up the tissue, as well as use arthroscopic tools to do their surgical technique. There's different types of grafts that can be used. For example, there is an autograft, which would be using the patient's own tissue. You can use an allograft, which is for a cadaver, so not the patient's original tissue, or a synthetic graft. So this is usually some type of engineered material, but I will say that they haven't had that much success with using different types of grafts. So there's different types of procedures. So you can have a muscle repair. So this typically they'll wait a couple of days, maybe 2 to 3 days, for the inflammation to decrease before they'll do the procedure. And the way that they'll do a muscle repair is they will take the ends of the torn muscle and they will either align them up or kind of overlap them, suture them together, and then immobilize the tissue to allow it to heal. You can also have a tendon repair, like a biceps tendon repair or Achilles tendon repair. This is done immediately or as soon as possible while the tendon is still relatively healthy. At a certain point, that tendon and that muscle will retract, and you will start to get necrosis of the tissue. So they like to do their tendon repair sooner rather than later. And as we mentioned in class, oftentimes they will immobilize the tendon in a shortened position to allow it to heal. Although we will see with some presentations and some current literature that they're starting to move away from that recommendation. You can have a repair or a reconstruction to ligaments. So the ACL is always reconstructed. They're not able to approximate the ends of the ACL to repair it, so they will use a different type of graft to completely make a new ACL. In these types of procedures, we will potentially have greater restrictions because ligaments provide a lot of stability to joints. We want to make sure that that heals well before we apply too much load to that. You can have different types of capsular stabilization or reconstructive type of procedures. You can have a capsulorrhaphy, which is also known as a capsular shift, which is the image that I have on the slide here. And what they do with a capsular shift is essentially they tighten that joint capsule, and it's done very commonly in the shoulder for people who are frequent dislocators. You can have a capsulolabral reconstruction, so that is where they will reconstruct not only the joint capsule but also the labrum around the joint. And there is a labrum in the hip and the shoulder, so we'll get to the shoulder in Ther Ex II. They can also do an electrothermally assisted capsulorrhaphy. So again, it's a capsular shift, except they use heat to it. So essentially the concept is that you are shrink wrapping the joint capsule. This was something that they did very commonly about 10 years ago, and they found that it didn't necessarily make the shoulder any more stable, and they actually found that it decreased the quality of the tissue, so I'm not sure that it's done as commonly anymore. So another type of procedure that can be done is a tendon transfer or realignment, and this is often done at the patellar tendon. What they'll do is they'll remove the tendon and attach it to the bone just in a different location. So they're basically relocating the origin or insertion of that muscle. Another procedure they can do is either release or lengthen a soft tissue. So these type of techniques are referred to as a myotomy. So this would be a lengthening of the muscle. And the images that I have here kind of demonstrate the shape that they will make the incision. So this is called a Z lengthening procedure, and then depending on the angle that they make the Z will tell you how much of an increase in length that you're going to get. So a myotomy is going to be an increase in muscle length, a tenotomy is going to be an increase in tendon length, and a fasciotomy would be an increase in fascia. The thing to keep in mind with this is that we want to increase the length of the tissue, but we don't necessarily want too much of an increase because we don't want to end up with laxity around the area. So they're often very cautious about doing these types of procedures. Moving on to the joint, we have different types of arthroscopic procedures. So we can do an arthroscopic debridement and lavage. So this would just be debriding and cleaning up any loose bodies, fibrotic tissue, maybe any flaps of extra cartilage or meniscus potentially. And then lavage means just to wash out. They can also do a synovectomy where they remove part of the synovial lining within the joint. This is often done when there's chronic inflammation, and they will do that arthroscopically. And they can also do several different types of articular cartilage procedures. So they can do a subchondral drilling, they can do an abrasion arthroplasty and a microfracture. The picture I have on the top right is an example of a microfracture. So what they will do is they will literally kind of either tap holes or bore holes within the bone, and the idea is it's trying to stimulate growth and healing of that tissue. They can also do a chondrocyte transplantation, and with this procedure they will typically harvest healthy cartilage from the patient. They will grow this within a lab somewhere, and then they will implant this back within the patient. And again, this is to try to stimulate cartilage growth. They can also do different types of osteochondral autografts and allografts. So osteochondral means they're taking the patient's own bone and they're using that as a filler for any type of cartilage procedure. They can also take it from a cadaver, and that would be our allograft. The reason why they do these cartilage procedures is that cartilage does not heal very well on its own. So if we just left it, it wouldn't repair itself. So we need to do some type of procedure. Moving on to our joint procedures, we have our arthroplasties, which can be total or hemi-arthroplasties, and this is where we don't really replace the joint, but we resurface the joint. So on the bottom left here, this is an example of a total hip arthroplasty, and you can see the acetabulum was replaced, as well as the femoral head and neck, as well as kind of the body through here. Here we have a total knee replacement here, and this would be a hemi-arthroplasty where they did part of the knee. You can also have a procedure called an arthrodesis. An arthrodesis, this image is specifically of the ankle, and what they do is they will do internal fixation using screws, pins, rods, things like that to fuse the ankle joint into a specific position. This is often done when an arthroplasty type procedure is not appropriate. We can also have extra-articular bony procedures, and this is where the procedure is outside of the joint itself. You can have something called an ORIF, which is an open reduction internal fixation, so ORIF. And this image here is showing kind of these plates and screws that are used to stabilize fractures. And then we can also have something called an osteotomy, this one specifically of the tibia here, where we have some poor alignment of our tibia that's affecting our knee biomechanics. And what they've done is they've gone in and they've realigned the tibia, and they've had to use some screws to kind of reorganize that bone. So these are different surgical procedures, and they are going to affect your rehab.